Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com, and I want to create some awareness today. The title of this video is going to be something like, be really careful with any cases that have had a history of oral facial trauma, automobile trauma, trauma on a bike, trauma on a skateboard in terms of future orthodontics. And I'm hoping y'all have a pretty detailed medical and dental history. I'm hoping there's a section in your dental history about history of trauma, but it's even something you might even want to ask. I especially keep on the lookout for kind of funny bites, or when the patient's giving their chief complaint, if they mention something like, I had braces, everything was good, and then I got in a car accident and now my bite is funny, something like that. Or I got, in a skateboarding accident or a skiing accident and my bite's never been the same. That's a major red flag for me. And I just wanted to create some awareness about it, about why. So of course, you guys are listening to this, you're probably mostly general dentists, pediatric dentists. Of course, you understand the tooth part of it. Did you bump your teeth? Okay, great. Let's take an x-ray. Let's take a PA. Let's check for the PDL. Let's check for the lamina dura. Let's check for root resorption. That's pretty obvious, I'm sure. I'm sure you know that any teeth that have been traumatized have a higher likelihood of getting root resorption and root blunting, pulpal necrosis during orthodontic treatment. It's in every single informed consent, be it Invisalign or standard braces one. That is something that patients do need to know if it was the teeth. And then certainly it's not that I wouldn't take a case like that if it was just the teeth. But I certainly, if I saw something funny in the x-ray, would send them to endo first before I even committed to the case for a sign off that they gave me the clearance to go ahead and proceed. Sometimes they do, sometimes they don't. And I'd get that in writing. So that's teeth related if I saw anything funny. And then whatever endo says goes, whether they clear it or they don't. Sometimes they'll clear it and then they'll say follow up regularly with x-rays. Usually for me, even if I didn't see anything funny in the x-ray, and even if I didn't send to endo, I would still flag those teeth. I'd put a little pop-up note or something that popped up every few months saying, take a PA, and I would x-ray that every 2 to 3 months. That's pretty much standard of care just to look for root resorption. You're gonna forget, so you need to put that alert in the treatment plan, and you also need to let the patient know ahead of time that you will be monitoring those teeth every few months, and that frequent x-rays will be included and will be part of the standard treatment plan if they want to proceed. Okay, so that's the teeth. That's standard stuff. I'm sure you guys get that stuff. Let's talk about bones. So, obviously, if I take a pano and I see a bunch of plates and screws, well, that's pretty much a dead giveaway. I probably will not do ortho on that patient. Okay, I would consult with an ortho because I am an orthodontist, because it's possible that might turn into a jaw surgery case. Things might go really weird. Really strange things can happen. And basically it turns into a whole different pricing structure to me, a whole different, got to go to OS first and get clearance. OMFS, one that actually has an MD usually and does jaw surgeries just in case, just to give me the A-OK to move the teeth within the bone with the plates and the screws. Okay, so I don't recommend that any GP takes a former trauma case or a former jaw surgery case. Don't do it. So many strange things can happen. Once you start it, you got to finish it, and you need to be able to manage everything that comes up, even if it includes jaw surgery. So just don't do it. If you see plates and screws, it's a no-go. Refer to ortho. That's a red light case. Even if you don't see plates and screws, but you've heard history of trauma, you see a funny bite, or the patient mentioned the bite has shifted, that's where this is the gray area. And this is what I do. I recommend, now that we've got good CBCTs, whether you have one in your office or you can refer out to a center, get a CBCT of the jaws, and have a company like Beam Readers. And I know I always mention Beam Readers just because I've talked to them. I know how they work. I know their reports. I know they do good work. I'm sure there are plenty other dental radiology companies out there that do great work as well and that are affordable. And if you are one, and by the way, I get no compensation from referring to them. It's just good karma, I guess. But if you are one, I'd love to talk to you, because I'd love to be able to drop some other names. If someone else does good work, I'll ask you for a sample report, things like that, just to make sure that it's up to the quality I want. But I know someone like Beam Readers would take that CBCT, and it won't be free, whether, even if you take the x-ray in-house, the reading will cost something. So whether you build this into the pricing structure, and this is really a matter of how you want to do this. Usually for me, at this point, we don't even know if we're taking the case. We don't even know if there's an all clear. So I'm going to tell them, hey, look, there's a bunch of red flags on this case. I'm going to need to go ahead and take a CBCT. There is going to be a cost for this, you know, but it's peace of mind for you. If there is any scar tissue, I'm calling it scar tissue, and there's probably a better way. And if you are a dental radiologist and you're listening to this, please correct me and tell me what I'm talking about. But, you know, let's say there was a minor fracture that even the patient didn't even know about. I mean, a lot of times you get into trauma and there's a minor fracture and it doesn't need to be set. You don't need plates and screws. It just heals itself. But in healing itself, it creates, you know, some type of bump or lineage or demarcation, or it just, the joint, you know, where it heals, where it fuses is not, you know, seamless. So teeth don't move predictably in that area. Okay, that's what I'm talking about. And again, you guys, I did a lot of osteoblast research when I did my residency, and got a master's too, and that was pretty much my thing. So I'm probably calling it the wrong thing, but basically, if I had to explain it, I'd say teeth don't move well in an area of scar tissue. So I would want the beam readers or affiliate or similar company to read that CBCT of the maxilla and the mandible both together, and look for any issues in the bone of pathology that might affect the movement of teeth. You can say patient has had a history of trauma, something like that. So just, I know it's going to be a couple $100, but it is totally worth it. Not only standard of care for you, because if you start moving teeth in an area where there's trauma, and if it's bumping into it, it's going to resorb that tooth. And now you're liable because you didn't do this. You, the doctor, are liable. And I would be mad if I was a patient, if you rushed into a case and you didn't do what you needed to do, you know, at least advise the patient. Even if there was an area of trauma, you could always not move that tooth. There's a lot of things you can do, especially with Invisalign or clear aligner cases. You can say, don't move tooth number 19. Just lock it. You know, I'm not going to move the teeth in this area. Sometimes you can still get a great outcome and just not move those teeth. So there's a lot of ways to work around, you know, and sometimes you can't. Sometimes it's like, okay, there's no way for me to take this case without doing damage or making the bite worse. So I'm going to pass on this case, or the only way we can take this case is to do jaw surgery. So that's why you need to have that reading done. So hopefully that was helpful. Thank you.